Welcome to the Clinical Pre-Hospital Care Research Forum Journal Club. Here in our PCRF Journal Club, we promote evidence-based practices by critically evaluating the latest science in emergency medical services. We hope our discussion will help advance EMS practice. Through the generous support of our sponsors, Limmer Education and ESO, we are able to make science more accessible and understandable.
All right. Good morning or afternoon, everyone. Welcome to the first PCRF podcast of 2026, the January edition of our Journal Club. I do want to thank our sponsors, Limmer Education and ESO, for making it possible for us to get together today. I'm Remley Crow, and today I am joined by Dr. Tony Fernandez, Jeff Rollman, Michael Caduce, and Dr. Bill Toon. And as always, the discussion today will be paired with an article written by our very own columnist, Michael Caduce, in EMS World called Journal Watch. So I encourage those of you listening, check it out. It is at emsworld.com under the category of education and training. And those of you in the audience who are listening live, I want to thank you for joining us and remind you that you can use your chat feature on your screen and type in questions or comments, and we can bring those into the discussion as we go. For those of you tuning in after the fact, thank you also for listening. As a reminder, the name of the article that we are reviewing today is, let's see if I can say this word, Methoxyflurane Exposure in Ambulances, a controlled laboratory study on paramedic safety, published in a journal that we don't regularly review, the Regulatory Toxicology and Pharmacology Journal. So today's paper is exciting because it hits at the crossroads of a lot of things that we care deeply about and that we've talked about some on the podcast: pain management, paramedic safety, and policy. So we know that pain is one of the most common reasons that patients call 911. We know it's one of the most consistently undertreated conditions in pre-hospital care. And so over the last several years, there's been more attention to pain management, especially non-opioid options, as we are still dealing with the opioid epidemic and there are fear around opioids and other things. And one of these alternative medications is methoxyflurane, also known as Penthrox or the green whistle. And it's a really powerful tool for trauma, for procedural pain, fast-acting, non-opioid, uniquely suited for pre-hospital environment. But I don't need to steal all of the thunder because I'm super excited that we are joined by some of the authorship of this great paper. So we have with us Zachary Cantor and Michael Austin, and we're going to walk through how the study was done, why it was done, how it was designed, what are the results, what they mean, and how EMS agencies can use this information moving forward. But before we go straight into the study, I want to start off with some introductions. So perhaps we can hear a little bit about your background, what drew you to EMS research, and maybe even what drew you particularly to this question. So Zach, I'll start with you. Thank you for being here.
Awesome. Thanks, Remley. Thanks for having me. And thanks everyone for tuning in. So my name is Zach. I'm a paramedic here in Canada. I dabbled in frontline and community paramedicine and a supervisory role as well. My full-time role now is paramedic education, so responsible for the ongoing education of our region's paramedics. And then, like you mentioned, also have my fingers in research. And I started research actually before I became a paramedic, and I think one of the things that interests me was pediatrics, but also paramedic-led research and having a frontline voice in research. And it was really, really great to be able to continue doing that in my role, and we're excited to talk about this study.
And I'm excited to hear you talk about how important it is for paramedics to be part of frontline research. We say it all the time,
Absolutely.
But it really is. So great to have you with us.
Thank you.
And Michael, thank you for joining us.
No, and thanks for having us. Really excited about this study and just chatting about it. So my name is Michael Austin. I was a paramedic for about 15 years, both in Canada, the US. I worked in New Hampshire, and then I went to Australia and worked there, and that's where I was introduced to Penthrox or methoxyflurane. I started my research sort of interest while I was a paramedic in Australia and really had some questions. At that time, it was about oxygen and COPD. And it was one of those things similar to methoxyflurane is we've done things for so long that we just assume that they're good. And so it was really interesting to dive into some questions that we could actually answer. And that was exciting. And so I've continued that. I went to medical school in Australia. So now I'm an emergency physician here in Ottawa. And I'm also the medical director for the base hospital in the Eastern region, work with Zach there. And so we support and delegate to 1,500 paramedics. And I also have a bit of educational hats as one of the physician leads for training physicians to understand pre-hospital and transport medicine here in Canada, but also worldwide. So it's kind of exciting. So we're excited to talk about this study.
It is very exciting, and what a background in world traveler, and very interested to hear more of those perspectives, especially since this medication is not widely used in the United States. I'm not sure about how widely used it is in Canada, but I do know that it's popular in Australia. So before we dive into the study, maybe we can talk a little bit about what is methoxyflurane, how does it delivered, how is it used today or not used maybe?
Yeah, happy to answer that one. So, I think just to answer your question on, in Canada, it was just approved in 2018. So new to Canada, and there's some areas that are starting to use it, but widely used, as you said, in New Zealand and Australia. It is an anesthetic gas. It was sort of removed from, I would say, normal use from anesthetic world because of the nephro and hepatic toxicity that was occurring at those sort of higher levels in anesthetics. But it continued as an analgesic. It was shown to have some properties at lower doses with not the sort of risks and side effects. So in places like New Zealand and Australia, it's been used widely for almost 40 years without really any concerns around those things that sort of took it off the market back then. It doesn't really fit into any sort of pharmacology product. It is truly an anesthetic gas, and it is a pure gas. And the product comes as an inhaler or a whistle, they sometimes call it. And the medication comes as a liquid, and it evaporates over time. And it's self-administered, which is the nice thing about the medication, that the patient can self-administer for their own pain management.
Perfect. And I think it's helpful to have some of that context on it. In the United States, for example, that medication was removed by the FDA. There were concerns, I believe, about kidney function is what resulted in it being taken off the market here. But there are currently some ongoing clinical trials to be aware of, and that landscape could evolve and could change for us. But currently it is approved in Canada. It's widely used in Australia, and definitely something for us in the US to keep our eyes on and learn more about. So as you took on this study, I'm curious about what were you seeing in EMS operations or just in general that made you think we need to have better data on this, or we should undertake this study question?
Yeah, it really stemmed from it being new in Canada, and we wanted to both see how it could be applied in the context in Ontario and in Canada. And as we sort of engaged in some reviews and some clinical trials, we've sort of organized 3 trials around methoxyflurane. One was a feasibility trial to look at a larger clinical-based trial, which we just completed, of about 2,300 patients, and it was really looking at current practice compared to adding methoxyflurane. But as we engaged in that, there was discussion, questions. When we dug into the literature, there wasn't a lot of evidence around the risk to paramedics. And to be honest, paramedics are putting their hand up going, well, what's the risk to me? And we sort of looked into the literature. And to be honest, there wasn't a really robust study that sort of answered the questions that we wanted to answer. One was, is it risky to paramedics? How much? Is a risk. So can they use it 1 time, 2 times, 3 times, 4 times? Because as soon as you put a threshold, which a lot of sort of guidelines and protocols put thresholds that you can only use it maybe 2, 3 times in a 12-hour shift, now you're limiting patient care because you can't offer them the treatments that can work in the context of some of the patients who are presenting. And so we wanted to sort of say, what is that threshold of use to ensure paramedics are comfortable and they have information at their fingertips to describe what the risk is to them? And that's sort of where, Zach and I and a group sort of sat down and said, how can we design something to evaluate that? We tried real world. We put some sensors in backs of trucks. We tried to evaluate it there. just wasn't possible. So we said, well, we're going to go back and we're going to do it in a lab-based study. And that was really exciting.
And I completely love this approach. I think in the absence of evidence, people make well-intentioned decisions around their protocols and, hey, you can only administer it this number of times on a shift. But it's important to have the data because perhaps patients are not getting the benefit of having their pain treated due to something where there isn't risk, or if there is risk, we should know about it and control it, of course. So I do want to talk about how you all conducted the study, because it was very controlled and very well calculated, because you all sought to answer the question under worst case scenario. And to help us explore some of the methodology, I'm going to invite Dr. Fernandez to come join us and just walk through some of the aspects of how the study was set up before we take a dive into the really cool results of it.
Awesome. Well, I want to thank you again for joining us today. I think this is a really cool study, and one that's very different from things that we've reviewed on this podcast before. So I'm excited to dive in. So let's talk about, again, if you could just remind us of what your hypothesis was, and if you had one, and what the objective of the study was. We can start there. That would be great.
You want me to get that one, Zach?
Sure, go for it, and I'll jump in.
Yeah, so yeah, that's okay. So, the study design was a non-clinical controlled laboratory study, and the reality is it was a little bit different than if we were to look at, say, a clinical trial where we actually have a number of patients or a number of participants that we need to answer the question. And this was probably one of the biggest things that we sort of engaged lots of experts and said, how many people do we need to answer the question in the context that we're trying to answer? Because we weren't really evaluating the participants as much as we were evaluating what the off-gassing, or the gas that was excreted from the participants into the ambulance or into the air, that we wanted to evaluate. So we engaged the Ottawa Hospital, which is a local hospital, and they have people who evaluate anesthetic departments, and they look at gas exposure. They look at lots of things in those environments. So they have methodology around that. And so we really utilized their expertise to evaluate how we were going to evaluate this. And so really, at the end of the day, we chose an N of 30. We said we got to get at least try to get 30 people to participate. But it really didn't matter. We just needed some people to participate, and then evaluate it in twofold. We wanted to evaluate it with ventilation system on. That system, the ambulance can sort of exchange the air every 2.5 minutes. And so we know that there's some safety profiles around having ventilation on. And then we wanted to say, well, what if they forget? Or what if the ventilation doesn't work? Is there an increased exposure if the ventilation system is off and the windows are closed, and the driver and or the paramedic in the back, what would their exposure look like? And so our hypothesis was a little bit open, in the sense that we actually didn't know, other than what the policies and a lot of guidelines were saying, is that there was a limit of 3. We wanted to find out, really our question was, what is the threshold, right? And in the sort of exposure literature, 2 parts per million of exposure is probably the threshold where we wanted to stay below. And sort of that sort of defines I'll say a top sort of number of safety platforms. And that's exposure of a gas. Where you get clinical symptoms is 15 parts per million. So there's a big sort of gap between, where our policy threshold might be, which is way down here at 2 parts per million, and where a clinical expected risk to that particular glass would be 15 parts per million. And so that was really our threshold question. And so when we started to extract and capture some of these gases, we kept that in mind.
Excellent. Thank you. And so before I really am fascinated about how you ran this and what happened during the day, but before we dive into that, we should kind of check off the boxes. Can you talk to us a little bit about how you identified folks who'd be eligible for this study, and how did you get them to participate?
Oh, go ahead, Zach. You're on mute.
Thank you. Thanks, Tony. I can tackle this one. So it's a great question. And really, to Mike's point, we wanted 30 participants to attend, and we ultimately ended up with 12, and we could talk through how we got to that number at the end. But really, we took a multi-stage approach to identifying participants. And so some of it was sending out cold emails, reaching out to some of our, running a convenience sample and reaching out to family and friends and some of the paramedic students as well in the region. We reached out to some of our paramedic services to see if they could distribute it to their paramedics to see if anyone would be interested. And that's sort of ultimately where we found our people. Now, given the potential risk for the medication, there was a multi-step screening process as well. So if people were interested in taking part in the study, I would have a quick chat with them, sort of determine some basic eligibility criteria. We would send them for some pre-screening blood work at the hospital to really ensure that their, liver and kidney functions were within normal limits. We would go through the typical informed consent process, and then we would schedule them for one of the days. And that's where we ended up with 12 people. Obviously, when it comes to research, it's a team sport, and there's a lot of logistics and moving parts, and the study is no different. So we borrowed an ambulance from one of our paramedic services, and we're grateful for their support for that. We ended up doing the study at one of our colleges, and obviously we couldn't have done it without them. And so in order to coordinate amongst all of those people, myself time, Mike's time, we ended up having 2 days to do the study, and that's where we ended up 12. So those were 12 people that were able to commit to those dates.
Excellent. And you made sure that they were, in order to be included, they had to be 18 years of age or older. And you did
Right.
the checks you made sure they had normal liver function, normal renal function, and all this was laboratory testing, was
Correct.
confirmed by laboratory testing.
By
So
the reference lab at the Ottawa Hospital. We also did repeat blood testing as soon as they were done the study procedure to also ensure that there were no ill effects of the methoxyflurane, and the participants were given their blood work for their own records and to bring to their physician if necessary.
yeah, really important. And I'm sure that gave your participants a sense of comfort to know that you were making sure that they were healthy enough to participate. So that was fantastic. Um,
Absolutely. And just to that point, actually, safety was the number one priority for us. And, myself as a paramedic, Mike as a physician, we were there. We had, a standard accoutrement of equipment if we needed. We informed the local hospital that the study was happening. There were, just to be clear, no adverse effects and nothing, but we were prepared, and we really want to ensure safety for everyone involved.
Yep, fantastic. Yep, and they were given a small token of your appreciation to participate,
They were.
and as well as maybe a little buzz from the medication. So um, I
We
feel
had
like
good
this is
satisfaction.
yeah, I'm sure. I feel like this was a good study for folks to volunteer for. All studies are good studies for folks to volunteer for, particularly this one. So let's dive into what happened on this day. So
Yeah.
you did this in the lab, right? And you had an actual ambulance and when you didn't have the ventilation system on, you did this in the lab, and then you took the ambulance out of the lab. Can you expand on that for our audience? Tell us like
Yeah, absolutely.
let us feel like we were actually there.
For sure. So the lab is kind of, one way to look at it was, almost a garage where we were able to bring the ambulance into the venue. It's actually where our police partners train. So there's a couple different rooms, and there's vehicles in there. There's a catwalk so you can see it all, but that's, just being a little bit pedantic. But the idea was we were able to bring the ambulance indoors. We had monitoring system in place. So not only were we able to virtually monitor their vital signs in real time, so their end-tidal CO2, their temperature, their respiratory rate, their blood pressure, their SATs, their oxygen SATs. We also had a camera inside the ambulance, and the participants had a headset similar to what Mike is wearing right now. So we were able to see them in real time and communicate with them in real time. So we had sensors strategically placed throughout the ambulance in both the patient compartment as well as the driver compartment. On the steering wheel, on the seat in the back, sort of on the jump seat, on the bench seat, various sensors around so that we can really get a fairly accurate representation of the off-gassing. And so we were monitoring them as they inhaled. So when the ventilation system was off, the ambulance was able to be indoors because it wasn't running. When we did the next phase, which was the ventilation system on, the ambulance has to be running, so we couldn't keep it indoors. So we brought it outside. But importantly, all of the remote monitoring was still working. So they were still being very, very they had a lot of eyes on them throughout the process. And so when the participant came in, we would do a initial set of vital signs to establish a baseline. We would walk them through what it involved. We would then give them the methoxyflurane. So this is sort of what it looks like. The medication goes in to the little wick here. It's just a liquid, and then it gets sort of absorbed as they breathe through. So we would orient them to how to use this device because this was new to a lot of people, myself included.
Sure.
And there's also a little bit of a noxious smell when you first open it. And so it was really important that the participants sort of understood what that smelled like and not to be taken aback by it. So, we set them up, we put on our 4-lead and our blood pressure and our end tidal. And so we could monitor and our non-invasive temperature so that we could monitor all of this. We put them in the back of the ambulance. We, confirmed that our live feed and we were able to talk to them was working. And then we went through the study protocol, which was taking a breath of the methoxyflurane every 20 seconds for 15 minutes. At the conclusion of that 15 minutes, we pulled them out. We did a final set of vitals. In addition to capturing their vitals throughout this 15 minutes, we drew their blood again, the same test that we did as a pre-screening. We sent those off to the lab, and then they were given appropriate discharge paperwork. Because they were, inhaling an anesthetic gas, we treated it like they sort of had a day surgery, if you will, and that we didn't want them operating heavy machinery for 24 hours. We ensured that they had someone to pick them up, and we called them later on that day just once again to make sure that there were no adverse events, and there were not.
That's great. And I'm really interested. So you have these sensors placed all around the ambulance. How did you determine the best spots for these sensors?
Yeah, so we relied heavily on the occupational health team to determine that. We also want it to be, pragmatic and generalizable, recognizing generally where paramedics sit within the ambulance. It wouldn't make sense if, the ambulance, if the paramedic sits here, we put a sensor, 10 feet away from them. So we really wanted it to be as close to real life as we could.
That makes a lot of sense. And you had a formula so you can kind of estimate how much exposure you'd want to, what the exposure period would be. Can you walk us through kind of where that came from and how you came up with this calculation?
Yeah, it stemmed from some of the feasibility work. As I said, we tried to pragmatically do this real live in the back of a truck, putting sensors, and we really didn't capture much. We did capture 3 episodes, and so we also identified there, even in the real world, that it was very low exposure. But what we did was we took that sort of data that we had out of about 100 patients and figured out what was the length of a normal transport or average transport in that sort of rural community. And again, city of about 100,000, covering a fairly large geographical area, and the average transport time was around 15 minutes. And so we used that as our sort of baseline. 15 minutes of transport in the ambulance was what we wanted to capture. And so that's where we came up with that. With regards to the breathing that Zach alluded to at the 20 seconds over 15 minutes, that 20-second sort of period was actually pulled from a paper where they were looking at using methoxyflurane for colonoscopies. And we just felt that was something that was already established in a protocol in another publication. So we figured that would be an adequate one to use. It probably overemphasized. It probably is using the drug more than a patient would. So we're really, again, worst case scenario, patients are probably not going to breathe that much of the methoxyflurane, but we felt that was a good protocol. And I sat out, as Zach alluded to, we had eyes on the patient, and I would just tell them to breathe every 20 seconds because you can imagine when they got to 10 minutes, they were pretty loopy, right? And so we just had to tell them, breathe now, and they would. And to be honest, our compliance was like 99% because we were right on them, and they were doing it for that 15 minutes. So we had a pretty good standard approach.
Did you have any kind of hurdles with the IRB for this?
Yeah, great question. So we didn't in the context that we, obviously consented all the participants. That was probably the biggest issue, right? Is this participant who is engaging in a medication not for pain. And so there was originally some discussions, is this off label, right? Is it outside of, the monograph? Because as you know, when monographs are created and things go through approvals through the governmental sort of system in FDA in the US, there's structures on indications for particular medications. And we were using this on participants who didn't have pain. And the indication for methoxyflurane is pain or procedure. And we weren't doing either. And so originally they said we needed to go to Health Canada and get approval for that. So we did that whole process with Health Canada. And then Health Canada turned around and said, we don't need you to do that. Right. So we
Oh,
did all the
no.
paperwork and then they said no. And so then we went back to our IRB and we said, listen, this is where we're at. And that process, once we had that sort of I'll say that question answered, then we were able to, work with the IRB, get the consent forms for the participants. Safety was really key. As Zach said, we were very clear that we were going to be screening everybody. And we did capture actually pre-fluoride levels. So methoxyflurane, the byproduct in the body is fluoride. So we captured fluoride levels before they ever used it, and most of them were 0, or some of them use fluoride toothpaste or have fluoride in their water, so a little bit. And then we know that everybody breathed in the methoxyflurane because their fluoride levels were up and on average well below the threshold of concern, but they were absolutely elevated. So that meant, they actually breathed in the medication, which was great.
Excellent, excellent. And it's in life, right? As in science, not everything goes as planned. Were there any kind of logistical hurdles that you faced during this process also?
I think the logistical hurdle. So once we actually started the study and had, the people, it went really, really smoothly. We were prepared. Classic paramedicine, things go wrong, and actually they didn't. I would say, the logistical hurdles was leading up to the day. So, finding the ambulance, finding the college, ensuring that those days worked, and then scheduling the people, because at the end of the day, a lot of these were working paramedics, so their shift work also. So there's a lot of logistical challenges in finding a day that was mutually worked for everyone. But short of that, I don't think there was anything major.
Love to hear that. That's awesome. Well, I cannot wait to get to your results. But before we do, I'd like to open this up to any other panelists who may have methods related questions. And then we can jump into these results because they're really interesting. I want to, again, thank you for your time and for this work. I think this is really, really cool and really adds to the literature.
Thank you.
And we do have an audience question that I'll bring in. I think it's a really interesting question from Sebastian around different ambulance configurations. So our audience here is international, and myself, I've worked on a lot of ambulances. In my head, when I was reading this paper, I realized I'm picturing the traditional square type 3 ambulance that has an open compartment between passenger and the driver. Do you all have any thoughts about testing this in other types of ambulances, like a smaller van? Could the results be different? Or what are your thoughts on how the actual configuration of an ambulance might affect what we see?
Yeah, it's interesting. There's been lots of questions now since we've completed this study on is there another way we could do it. I think from the results, and we're not going to talk about results right now, but the results were pretty powerful in the context of the potential risk and the low risk to even multiple uses, right? So I think in most ambulances, I think most ventilation systems are similar. In Canada, they're all standard, or at least in Ontario, they're all standardized across that they need to be able to exchange the air every 2.5 minutes. And I think if we look and dig into most ambulances in general, because of occupational exposures, most of them probably meet similar standards. And again, I can't speak internationally, but I think in general, if you're in an ambulance, I think most of them that have ventilation systems will probably be similar. So I think from that standpoint, I think if ventilation's on, I think there's probably a comparative. If no ventilation, I think what we demonstrated in our results is that the risk is probably low. So, even people are pulling this out and saying, if I did this in an office space where I'm doing procedures, what does that look like? And I said, well, it's kind of like what we used in an ambulance without the ventilation system on, and this would be the potential exposure. And so I think there is some, correlation. We aren't saying they're equal, but I think you can extrapolate a little bit. And I think the risks are low.
Yeah, I think that's very helpful that you had it in the 2 different settings, because not everybody has that ventilation system, as an example.
And just for clarity, we did use type 3 ambulances.
Type 3.
Yeah.
Well, see, that was what was in my head. No, but I think that was a really great question from Sebastian, because I was like, oh, I was making an assumption without actually having, read that perhaps.
Yeah. And the follow-up question we get a lot is, would this work in a helicopter, or would this be safe in a helicopter? And to Mike's point, a lot of those parallels.
Yeah. Dr. Toon.
So this no, that's not for you. Uh, my question is I don't know if ambulances, you said yours are set up to do an exchange of air, cycle air versus some were just venting off from the inside. And I don't know if they actually exchanged air. And it makes me think of operating rooms I know that have scavenger systems for anesthetic gases. And again, not understanding what that standard is, a scavenging system versus, something that truly circulates the air versus something that just vents air out. And again, it's been a while since I've been in an ambulance, but most of my past experiences, all it was a way to vent air out, not necessarily exchange. And US, I'm thinking. So I was just curious your thoughts on that.
Yeah, and I don't know all of the ambulance structures, but I think the evaluation, at least in Ontario from a standard standpoint, is about that concept that the system, the ventilation, the fan that's on is pushing air out of that compartment. And so the method to evaluate that is by exchange of air. And so they were describing that in the context of 2.5 minutes that it would take that air and move it out, and obviously exchange. And I think a lot of if the fan is blowing out into the atmosphere or out into the air, then I think it will exchange at some rate, right? And it probably can be defined. With regards to anesthetic rooms, scavenger systems or anesthetic compartments, right, in the world of operating rooms are a closed system, right? This is not a closed system. This is an open system, and there's no tubes and anything that's capturing that. Although when Zach held up the methoxyflurane, you'll see that there's a carbon cartridge which has been added to the inhaler. And the reason why they added that was they felt that could be more like a closed system where if the patient breathes in, they breathe the medication in. If they blow out through the inhaler, then the carbon cartridge will capture some of that off-gassing. Again, when I used methoxyflurane in Australia back in sort of 2003, when I was a paramedic there, we didn't have that carbon cartridge. We were just using it, right? And then they added that since. I don't think anybody's evaluated it with an on or off. And somebody asked us that question, are you going to take the cartridge off and try it? I said, well, they all come with cartridges now. So I don't know if that would be beneficial. Yeah.
I think this is great context, especially as we think about, what are the next studies that build on this and continue to advance this knowledge. Another methods related question that has come in from our audience is about the candidate screening. So among the candidates, were there any individuals with a known history of diabetes, as we know that diabetes can impair renal function and potentially have issues with this medication. So would like to hear from you all. Did this exposure have any impact on renal function? Were these patients part of that group that might get excluded, or any thoughts around comorbidities?
Yeah, so from a lot of the evidence that's been done around the use of methoxyflurane on patients themselves, again, people aren't being pre-screened, although the risks to patients really is about that known history of renal, liver, malignant hypothermia, other risk factors that define a gas. In our study, we didn't have anyone with those risk factors, and we evaluated their renal function and their liver function prior. So we screened them medically with a history, and then, as Zach said, and then we did the blood work to ensure that it was correct, that they didn't have anything. Again, we excluded those who did, and there were a few that we excluded, but at the end of the day, we picked that cohort of population at the lowest risk for this particular study. It's a low dose, and so we ensured that. Our population was great because we actually had a fairly broad population of ages, right? Like we just didn't have 20-year-olds, right? So we actually had, people in their 60s doing this study for us, which was great because we really wanted to understand, one, from a risk standpoint, but two, really, people as they age, their breathing physiology changes, right? Their ability to absorb things change. Males and females are different. And so it's important for us to, look at the cohort that's actually being the participant, because we wanted that participant to be somewhat representative. And it was, I think, in that context, even though we had 12.
And just to answer the second part of your question there, Sebastian, we did do the repeat blood work and there was no impact on the renal function as well. Or any functions for that matter.
Jeff, you've got a question.
Yes, yeah. First off, just want to thank both of you for joining us and really sharing this excellent study. It's definitely really interesting to hear about this work. And this is a bit different than the papers that we typically talk about that tend to be more observational in nature. So with this being the controlled laboratory study and not necessarily a observational or field study, we know that you're able to control a lot of things really well. But at the same time, some of that kind of real world variability that we might see in observational studies, obviously you can't replicate that in laboratory setting. So just wondering, before we go into our results, if you could talk a little bit about sort of the internal versus external validity to give our audience a little bit more context in terms of things to think about.
Yeah, so I think one of them I touched a little bit on is the different age population, or that population of patients that paramedics will see and maybe use methoxyflurane in the real world. And I think one of our conscious approaches, we wanted a split of males and females, and we had that. And we also wanted a variety of ages, and we were able to sort of get volunteers or participants to be able to do that. So I think that helps with that sort of difference between a lab versus real world in the context of the use of the medications. The other thing is we controlled a very structured regiment around every 20 seconds for that 15 minutes. And so I think that demonstrated probably worst case scenario if a patient had a broken leg and they were using the methoxyflurane, they probably wouldn't breathe it to that extent. So we were probably enhancing the amount of methoxy used in the back of the truck in compared to the real world scenario in the context of that. And so I think those two parts really sort of define that. The nice thing about the laboratory study was really the question that we had, which was really about capturing the gases. And what we were able to control was all parts of the capturing of the gas. So every time a participant went into the truck, like each of the sensors were capped. When they were removed from the trucks, there was a very specific process where they got put on ice. They got controlled. We didn't lose any gas. We didn't lose any parts of the devices themselves that were capturing the gas. Were well structured and met the highest standard to both capture, store, and then send to the lab. And then the lab evaluated them by the processes that they would do. So we're pretty sure that chain of collection was well sought and well thought about, but we didn't lose any there. So I think that's really key, is because I think gases themselves will dissolve and they'll go everywhere. And so how do we know that we didn't lose some? Well, I can tell you that we were really, really structured, and we use experts to do that. And Somalin, who was our expert, she spent a long time with us running around in the ambulances, taking these things out and putting them on ice and controlling them and capping them. And it was quite amazing to watch her work, because she was very structured and held to that highest level of standard, which was great.
The other thing I'd like to add to that is, just to elaborate on Mike's point of, yes, I think, breathing Q20 seconds for 15 minutes is not realistic for our patient population. The other thing to consider is, in this scenario, they only inhaled the methoxyflurane in the back of an ambulance, which I also think in real life isn't necessarily true. We know that patients are going to do it, to extricate them off the ground, to get them from the floor to the stretcher in their apartment, in, whether it's on the beach, whether they're outside, whether it's on a ski hill, to get them down. And so, patients are going to inhale the methoxyflurane as you're wheeling them to the ambulance. And so there's other scenarios where they're not going to be confined in the back of an ambulance, where they're going to be inhaling this medication. So to that point, I think really we were set up for that worst case scenario where they're breathing it frequently and often in the smallest possible way. And I don't think that is realistic of the scenarios we as paramedics find ourselves with these patients.
Yeah, thank you. I think you did a really nice job walking through that and explaining that, because I know some EMTs and paramedics might think, oh, this isn't relevant to me. This is just in a lab. But this is truly, like you said, that worst case scenario, super conservative, that we could think these are the numbers they're getting in the lab. Out in the real world, yeah, shouldn't even really be getting close to those numbers. So thank you.
And I think, part of it too is it is, I think, relevant to a lot of providers, whether it's EMT or paramedic, in that this is a non-opiate treatment. And when we look at equitable healthcare and access to healthcare here in Ontario, it's the advanced care paramedics that are the ones that carry the opiates, the fentanyl, the morphine, and now ketamine in our formulary, but not every patient has access to an advanced care paramedic. And so this is an opportunity for our BLS providers to be able to provide some very strong, effective analgesia.
I
And it
love
doesn't
that you.
require IVs, right? And it's
That's right.
self-administered by a patient. It's so nice to be able to give the patient their own treatment and then work on whatever you need to work on as a provider. It adds to that flexibility, I think, in care. One thing I didn't mention early on, just so everybody's aware, is that methoxyflurane is a gas. It's really bioavailability. It's water soluble in the context that when a person breathes it in, 85% of it stays in them. And that's the other benefit of it in the context that it's one's going to act appropriately and acts pretty quickly, but two, that they're not going to breathe much of it out. And that's why I think what we found in our results were aligned with some of the other research that wasn't done in a lab study, but demonstrated the safety profile.
Absolutely. And I love that you highlighted an additional tool in the toolkit with some really favorable properties and differences from what we traditionally carry. And here in the States, IV Tylenol or Offerm have lost its patent. So that one's becoming more affordable, but the barrier of still having to get IV access remains. So having something that does not involve a needle, I know I'm okay with putting needles in people, but I personally don't love having them shoved in me. So I can appreciate that.
And we know that it takes time to initiate that IV and to drop the medication and to administer. And just because you want to give someone an opiate doesn't mean they're getting it, right away. And so the Penthrox you can effectively deliver almost right away.
And before we move them around and jostle them is really critical. I love that you highlighted that.
As a bridge therapy.
Yes. Let's talk about the results. So I'm curious what surprised you the most when the results came back in, or maybe there weren't any surprises.
I think for me, pragmatically, what surprised me the most was how safe it is. And I, to be honest with you, wasn't expecting to see numbers that we saw. And maybe Mike, you can explain the numbers a little bit more. But I know for me as almost as a frontline provider, I think that was the number one thing that jumped out at me, is that I could feel confident that if I had this in my toolkit, that I would feel comfortable giving it to my patients.
Yeah, I agree with you. I figured we would come out with a threshold of 10 maybe in a shift, right? That would not limit patient care, but it would absolutely provide paramedics a level of, safety profile where they could feel comfortable. And I think I agree with Zach. I think I was a bit surprised that even cumulative levels, and just to give people a sense, so we put sensors in the back of the truck. The participants did that 50 minutes. We had multiple sensors that we put in. We took one of them out after one participant, but left others in there, right? So that would be a 30-minute exposure, then a 45-minute exposure, and then a 60-minute exposure, because each of those 15-minute intervals added up. And what we did was we took that period of time, which we had about an hour and a half of time, and we said, okay, now we have this length of time of exposure. And here's the threshold, right? It was well below the 2 parts per million as I described. What is it if we say the same sort of process of 15 minutes, a 30-minute transport with time to hand over the patient? If we looked at a 12-hour shift, then a paramedic potentially with a lunch break, right? Paramedics get lunch breaks, of course not, but if they had a lunch break, that they could potentially treat 22 patients, right? Half-hour windows over a 12-hour shift, right? With the lunch break and handovers. So if we did that, what would that number look like? And what we saw, and if you looked at the graphs in the paper, is if the ventilation system was on, the actual value was less than 0.5. So it was still way below the 2 parts per million. And if you were the driver, so that's in the back of the truck. If you were the driver, it was almost zero. There was no exposure if you have the ventilation system on, right? And if you didn't have the ventilation system on, so your worst case scenario, it still was well below the 2 parts per million and below the 1.5, right? So remember I told you 2 was that threshold that the most policies will set, and then 15 parts per million is where that clinical, potential risk is. So it's well below that. And so what that really tells us is that paramedics in general and use this safely and feel comfortable that when they're in the back of their truck, that they can provide great pain management if the patient needs it and they can offer it, and the patient they can know that it's not harming them in any way with any sort of exposures that are risky to them. And I think that's really, really nice. We get lots of questions about pregnancy, right? Well, what if, and that's up to them to make that decision. I don't ever tell them you can or you can't, but I think the evidence here, if you were driving and you were pregnant, the risk would be incredibly low, right? So if you got exposed for whatever reason, you can be reassured that we looked at the numbers. And so you could look at some of these things and at least say, oh, the exposure was really low.
Yeah, and I think that's important. This was the worst case scenario of one wild shift where everybody broke everything.
Yep.
Right. That would very unrealistic that it would happen to in one shift, but somebody it might happen. But I think that this is very reassuring in terms of those safety considerations that were so far under the clinical concern that we would have, and we're underneath what most policies have as well. There's a question from the audience that I think is helpful to discuss. So, here we've got the ventilation system. Let's say I'm working in a system where there isn't a ventilation system. Is there any personal protective equipment that paramedics could use to further reduce their risks?
It's a great question. It was lots. Oh, go ahead, Zach.
No, all you, Mike.
Oh, I was just going to say we had lots of questions. People would even wear their masks or put on even their PAPRs. But the reality is you need very specific filters to filter out methoxyflurane. It's an incredibly small product, and it would take a lot to sort of limit that exposure. So really, the answer is no in a practical sense, that you won't be able to use any sort of mask devices that would reduce your risk. But what I can say is that exposure is low, right? So obviously, if you're at risk, then I still wouldn't use it. But the reality is, for the general population out there that's using this in the back of trucks, the risk is low. Yeah.
Absolutely. One additional thought or question that extends beyond the scope of this study, but curious in your reading on this topic, do exposures stack? Let's say I had 3 worst case scenario shifts in the same week. Is it likely that this medication stays in my system? Should there be concerns on repeated exposure over time, not just within a single shift?
Yeah, and I would say that's an unanswered question, although I would say that, in the monographs that most of the products have been approved for, 6 mils, so it comes in a 3 mil vial, 6 mils in a day, so 24 hours, right? So that can be the dose. And then typically they want you to not have it again for a period of time as a patient. Again, as a patient who's receiving this medication, who's breathing in and absorbing 85% of that, that's sort of the recommendation, right? You have a 3 sort of month window. The reality is, in a paramedic world, the exposures that you're getting are so low, and the amount that your body will break down usually within 30 minutes to an hour, right? So the reality is, cumulative exposure is an unanswered one, but I would say in general, from what we see in the safety profile of patients using the medication, the risks are fairly low because it's such a low dose, right? And that's the reason. Fluoride itself is broken down by the human body, so it will be broken down by paramedics even at that low exposure rate.
And given these results, if you all were thinking about writing EMS protocols tomorrow, what would you change?
Well, it's funny you mentioned that. We're in the process of doing that right now. And I would have no problem writing this into the direct for the protocol right now. With
and
no
there would be a
ceiling
limitation, right,
yeah.
Zach? Yeah.
Right, no ceiling.
Yeah.
Yeah.
And the question too about, in the monograph themselves, it's about traumatic pain. I think there's
I was
lots
just
of
gonna say, yeah,
protocols out there and guidelines that have been using it for pain, not just for traumatic pain. And a lot of course, medications and guidance documents and protocols that are out there for EMTs and paramedics are off-label, right? And so there would be some potential to, engage in off-label use of this. I know there's a study being done in Nova Scotia looking at methoxyflurane for renal colic. So it's an emerge-based study. Patients coming in with renal colic given and followed by the nephrology group. So they're really looking at that population, right, who's having a renal-based problem, and seeing if it's efficacious, if it works, but also is there a risk to that population. So I think we'll have some evidence from that study to help to inform other patient populations, which may be included at least in the real world, right? It might not change the monograph, but I think the safety profile's there. Yeah.
That's really interesting. Wanted to ask you all about sort of the implications of this study, since we now know, based off of this really well done work, that these safety concerns are, I mean, even in the most conservative worst case scenario, that our EMS clinicians and patients should be all right. But for somebody maybe in the US, for medical directors that aren't used to seeing this used, and it's very much a novel, different treatment, what other considerations or things to keep in mind would you mention when it comes to implementing this protocol, training, storage? I don't know, just rough cost numbers if you maybe know, but since it seems like you've clearly had to become super knowledgeable about this, just how to implement it.
One of the things that I would say is not necessarily in general, people who use gases like this in the healthcare world is the knowledge around malignant hypothermia, and this is a potential risk for this population. So I would say when we did our education, one of the big sort of gaps that we recognize is that people don't think about that when they're giving treatments or offering treatments. And so understanding what that is and how you reduce that risk. And so a lot of people have come to us, well, how do you know? And I think we dug in a little bit into the literature to say, well, is taking a history enough? Right. And in first world, second world countries, most people know if they've got a family history of malignant hypothermia. And so it's very low risk in the context of providing this product in that population. Is if the history is, do you have a family or medical history of malignant hypothermia? You're pretty safe in that context, because the consequence of that could be death, right? So you don't want to give it to somebody who's got malignant hypothermia. So I think that's really important. The other is that, as I think, Zach, you had said it, the gas is quite potent at the front end, right? It's a strong odor. It's kind of like if you take a nail polish remover and you breathe it really fast. It's kind of that strong smell. And so, just telling paramedics to tell patients to have a little bit of a smell first, take a little bit of an inhalation so they get comfortable with it. Once you have a few breaths in of it, people and patients are very comfortable with using it, even though the smell is a little bit stronger. So that's fine. For paramedics, you'll smell it right away, right? The odor threshold is really low, right? So the risks we were talking about, the odor threshold is like 0.05. So you're going to smell it, but it doesn't mean you're being exposed to a high dose of this medication. It's just very strong odor. I don't know if you have anything else to add, Zach?
Yeah, I think that's a great point and a great distinction. And those are a lot of the education we had to get ahead of. Is just because you smell it doesn't mean you're actually being exposed. To that point about the malignant hyperthermia, that is why we had the non-invasive temperature monitoring. That's not a very typical ongoing vital sign. That's, whenever we're treating our patients with analgesia, and we were monitoring that in real time as well. The other logistical, consideration is the size of it and where to store it. And I think that's something, the ambulance service provider needs to consider. Here in Ontario, we're fairly highly regulated in terms of how heavy the bays can be from a health and safety point of view. Not to say that the device is heavy. I'm holding it right here, but it does take up quite a bit of room and quite a bit of space in a bag. So one of the things we need to consider is, if we're going to put this in a bag, does something need to come out to fit it? Like anything, it's a logistics question, and the cost as well. This is more expensive than some of the other analgesics on the market. But just some of the points we've spoken about, some of the pros to it. So, just having a fully informed discussion of what you're carrying would be my takeaway.
And in that same vein, I'm curious from your perspective, and this is beyond the current study, but from your experience in the field and as medical direction, qualitatively, what has been your experience with the paramedic either hesitancy or support of use? And then from the patient perspective as well, is this generally well received? Are there a lot of hesitations related to this? Just curious.
So before we're actually examining that right now, and I'll let Mike speak to that. But one of the questions, and this is anecdotal, of course, there's no actual evidence here, but one of the questions we asked our paramedics that went through this study, was kind of, how would you feel giving this to your patient? Do you think this would be an effective analgesic? And resoundingly, sorry, all of them said absolutely. They can see. Now, granted, they were not in pain themselves, but they all sort of felt that this would be a great analgesic option to keep in the toolbox.
And I think I mentioned that we did a feasibility study to evaluate two studies. One was really to see if we can get paramedics interest. So we did survey the paramedics around their use. And then we obviously tried to capture the off-gassing and look at some occupational exposure. And then we wanted to sort of inform our larger multi-centered study, which we're just in the process of doing some of the evaluation. We completed 2,300 patients. And we looked at current therapy where PCPs and ACPs were providing Tylenol, Advil, ketorolac, or an opioid compared to the addition of methoxyflurane. And so we wanted to really see, is this of benefit in Ontario's sort of environment with a bunch of medications that they already carry? And so we're going to answer that question, which I think is going to be exciting. And we're going to do a bit of a cost evaluation on that. So hopefully we'll publish that as well. So that'll help people to make some informed decisions. But I think one of the parts of I lost my train of thought there. But one of the parts of that we were talking about was paramedics who might be a little bit apprehensive. And so we did the feasibility study. There were a cohort that were. Once we've completed the occupational study, this study, they're less, because I think their concern was about this concept. And we probably introduced that a little bit because we said, we're going to be evaluating occupational exposure. We're going to be putting sensors in your trucks. So we probably created a little bit of that angst because we had to have them sign to do the study and part of the IRB. So we probably created a little bit of that, but we've shared with them the results of this study, which I think has reassured them that, yes, we actually evaluated the risk that they were concerned about. And so we didn't see that at all in the larger study that we just completed.
Absolutely. And time really does fly when you're having fun, which this study is certainly a very fun one. But I have that unenviable task of wrapping us up on time. But I like to give the authors a chance at the last word. And we really appreciate you all having shared your time with us. So I'm curious if there is a key message for clinicians, leaders, regulators that you hope that they'll take away, or something that you hope will change because of this study. And so, Zach, I can start with you on your last thoughts for the audience.
I have a lot of thoughts. This was a lot of fun to do. I think it was really important to challenge the status quo a little bit and, challenge that classic mantra just because we've always done it this way, and have a inquisitive mind, but also, and this is something that took me a while to know that I know a lot of my paramedic colleagues have as well. And that's, research is hard work. And if you're going to do it, make sure you do it right. And I think we did a very good job on this one of doing it right and letting the data speak for itself, and having a rigorous methodology, but also ensuring safety and balancing all of those really, really important factors. So, ask the question. Don't be scared to try it out.
Yeah, I love that attitude of curiosity on, well, they say this happens, but does it? It's a testable hypothesis. And I love how you all approach this question.
Absolutely. It's the classic paramedics hate two things: change and doing things the same. So sometimes it's time for some change.
But put some data behind it never hurts. I think that's really great.
Absolutely.
And Michael, some last words or takeaways?
No, that's great. No, I think for me, if you have a curiosity of any question and a curiosity of anything that you're doing, really dig into the literature and start reviewing what's out there first. And if you find that there isn't much out there, then there's a great opportunity to answer that question yourself. And I agree with Zach, it's a lot of work, but it is a lot of fun. We had a blast doing this study. It was very different than any of the other studies I've ever done, but really kind of fun to do in the context of, being able to answer a question really robustly, because a lot of clinical work that you do, it's very difficult to answer those questions with a pretty reassured result. I'll say from a standpoint of just the study results themselves, I think what we've demonstrated that this is very safe for paramedics, and I think that's exciting because now they can go out there and offer good analgesia for their paramedics if for their patients if they choose, without sort of having that concern. And I think from the regulatory sort of side of things or policy, people who develop and create policies, I think there's an opportunity to update those to make sure that things align with the evidence here, to show that there is safety around that, and that allows for best patient care. And I think that's what we're all here for, is patient-centered care. So.
Absolutely. A lot of work and a lot of fun. I think that sums it up well and is a good reminder to the audience on how important it is for paramedics to be involved in pre-hospital research, and lots of opportunities to get involved. It doesn't happen by yourself. It takes a team. So definitely make sure to check out prehospitalcare.org. There's some more 3-day workshops coming up this year. A great way to just dip your feet in the water and see if research is for you. But we have reached the end of our time. So I want to thank again these authors, one, for doing the study so rigorously, because it was a lot of work and it was really well done. And thank you also for taking time out of your day to share this work with us. We appreciate having you here. Thank you.
Thank you for the invite.
Oh, thank you. It's great.
And I have a few wrap-up announcements for those of you still listening. So as a reminder, we've got the Education Journal Club version of this podcast. That'll be Friday, January 23rd. And then we will be back here with the clinical podcast, second Monday of every month. That'll be February 9th at noon Central. Thank you all for listening and kicking off this year strong with us. We look forward to hanging out again and nerding out with you in February. All right.
We hope you have enjoyed and learned from this PCRF Journal Club. Please share it with other interested EMS professionals. An archive of past journal clubs can be found at pcrfpodcasts.org. You can also find us on Facebook at PCRF at UCLA and on our website, prehospitalcare.org. A special thank you to our sponsors, Limmer Education, providing educational tools for success at every stage of your EMS journey, and ESO, dedicated to improving community health and safety through the power of data.